today to share our experience in very important issue, talking about the interventional issue, very important, related to great health problem, which is the cancer liver and the cancer pancreas. And of course, now we're talking about a new hope, a new practically validated method, which is Haifu. Of course, it's honor today to meet Dr. Simon, Dr. Vidal, Dr. Meng, Dr. Zhou, and Dr. Yang. They have, of course, a great experience in treating many patients with cancer liver and cancer pancreas. So I think today it's somehow an open discussion how to put our beloved technology, our emerging excellent technology, how we can share our experience to put it on the guideline or even as a chosen treatment method for very important disease like liver and pancreatic cancer. It's a great today as we have many specialty. We have a surgeon, we have an oncologist, we have an interventionist, we have an Haifu specialist participating in this meeting. And I think at the end of our meeting, we can find some ideas to make it validated on the ground. First of all, I want to invite Professor Simon to introduce his talk. He will talking about the Haifu treatment for liver and the pancreatic tumor, for the liver tumor in difficult location. Of course, Professor Simon is a surgeon, and he is a respectable professor in liver surgery. So he can give us a great and clear idea about the Haifu as a surgeon, what he think about it, and how he can provide a good alternative for the patient. Please, Professor Simon, the ground is yours.
Thank you. I'll just share my screen. Can you see my slide?
Yes.
Yep. Hi. Hi. Good day, everyone. I'm Simon Zhang from the Department of Surgery at the University of Hong Kong, and I'm honored to be invited to give to share my experience regarding the use of high-intensity focused ultrasound for treatment of liver tumors in difficult locations. First of all, I have nothing to declare in terms of conflict of interest. And just a little bit of background regarding the treatment options, because in fact, in our locality, hepatocellular carcinoma is one of the commonest cancers, one of the commonest primary cancers we encounter in our practice. But unfortunately, up to 75% of these patients are not suitable for liver resection for various reasons. And the most common reason for unresectability is the presence of cirrhosis. And so the treatment options are rather limited. And they include, in the presence of mild cirrhosis like child pugh A disease, then a limited resection such as a wedge resection or a segmentectomy may be performed. But in certain cases where resection is deemed to be dangerous or too invasive, or the liver's too cirrhotic because of poor indocyanine green retention tests or the degree of portal hypertension, then we may actually opt for radiofrequency ablation or microwave ablation of these local tumors if they're small enough, like less than 3 centimeters in size. Other tumors may be treated by stereotactic radiation therapy, And multifocal disease may be used to treat, may be amenable to transarterial chemoembolization. And there's also the option of liver transplantation in selected cases if they fulfill the UCSF criteria. But unfortunately, in our locality, because of the scarcity of liver grafts, that is not often the case. And we may just have to opt for ablation in some of these for local disease. And some patients with systemic disease may need systemic therapy as well. And Haifu has its use because it is non-invasive. It is a transcutaneous treatment, and it is well tolerated by patients. I'm not going to go into the basics of Haifu because that's not part of this talk. But what we have to share, what we have to understand here is that Haifu can be offered if the liver tumor, if it's solitary, if it's less than 5 centimeters in size, it may be suitable. And we only offer Haifu if there is unresectable disease, or if we consider after multidisciplinary meeting that radiofrequency ablation or microwave ablation is not feasible. And in fact, if there is ascites, then radiofrequency ablation may not be the best treatment because of the risk of bleeding. And also there's a risk of liver decompensation as well. Whereas in Haifu, we have shown that the presence of ascites is not a contraindication. And we can even perform Haifu ablation in the presence of advanced cirrhosis in patients with child B or child C cirrhosis, as long as there is no evidence of hepatic encephalopathy. And because this is a transcutaneous treatment without any wounds, then the recovery is very quick. The majority of our patients, in fact, over 90% of our patients can go home the following day. And we, for tumors that are smaller than 3 centimeters, we have shown that the complete ablation rate may be up to 68% after 1 session of treatment with Haifu. But then there are certain contraindications for Haifu against HCC. This procedure has to be done with breath holding and it has to be done under general anesthesia. So if the patient is medically unfit for general anesthesia, then we should not offer Haifu. And if there's any evidence of major vascular invasion, such as main portal vein or side branch portal vein invasion of the tumor, then we should not give Haifu. If there's evidence of extrahepatic disease or direct invasion into the surrounding organs, like invasion into the colon, invasion into the gallbladder, then Haifu is contraindicated. And last and not least, if we cannot see the tumor with ultrasound, because our system is ultrasound based, if we cannot see the tumor, then we cannot treat it because that's the physics involved. If the sound waves cannot get to the tumor by localization, then we cannot treat it. And most and foremost, the patient's skin condition has to be satisfactory as well. And this is a system we use, which is the JC system from Chongqing Haifu Technology Company. And we've been using this very reliable workhorse for over 10 years. And it served us very well. And it's benefited hundreds of patients in our center. And the patient is typically treated under general anesthesia for ablation of liver tumors. And it comprises of a console, which is a control console. There's an imaging system with ultrasound, real-time ultrasound guidance in a water bath, and the patient lies either on the prone position or in the right lateral position for ablation with a treatment transducer, which is embedded inside the system here. And so, unfortunately, because this is a transcutaneous ultrasound-guided ablation system, then there are difficult locations. Some parts of the tumor, when they're located in the dome of the liver, for example, in the dome of segment 8 or segment 7, the liver dome is actually surrounded by the diaphragm, lung around it, surrounded by rib cage in front and to the sides as well. So you can't see it very well. And there's also risk of other locations may sustain thermal injury if we're not careful. For example, if the tumor is located in the dome of the liver on the left liver, such as the left lateral section, if you're not careful, you may actually injure the heart because the ultrasound energy travels, and as it traverses the surrounding tissues, it may cause injury to the surrounding collateral structures, such as the heart, or if you're close to the bile ducts, it may actually cause biliary duct injury, resulting in biloma or liver abscess. You may injure major blood vessels, risk of injury to hollow organs, such as to the gallbladder, to the stomach, the duodenum, or the bowel, such as the colon as well. And I'm going to show you a few cases here. Whenever we do Haifu ablation, we always make sure that prior to the procedure under general anesthesia, we have to make sure that we can actually see the tumor. So we always have axial imaging, such as a CT scan or MRI available to us, and we review the image. And here we can see that there's a tumor situated in segment 7 of the liver, close to the dome, situated pretty high up. As you can see here, it's surrounded by lung tissue, surrounded by a little bit of ascites, a very cirrhotic liver. And imagine that if you're going to do a transcutaneous ultrasound, it's going to be rather difficult if you do it from the side, from the abdominal wall, from the chest wall. But whereas if you do it in the lower position, if you do it subhepatically, if you place a probe and pointing it towards the head, pointing at cephalic and angulating it, then you easily visualize the dome, even in the presence of air around the dome, because you're actually looking from down upwards. You're looking up towards the head of the patient, towards the right shoulder. And so you're going to be able to visualize the tumor. So, okay, we're happy with that. We're going to anesthetize the patient. We place the patient on the machine, and we also ensure that we can actually visualize it using the ultrasound transducer in the Haifu JC system machine. Placed in the right lateral position. And here you can actually tilt and angulate the transducer towards the head end. To the right side of this video is the head end, left side is the foot. And here we're actually using the motor to tilt it towards the head. And you can see it's tilting, and you're going to be able to visualize lesions close to the dome of the liver. As you can see here in the schematic diagram down below, you're tilting it towards the head direction, so you're going to be able to see it. But unfortunately, it's still surrounded by diaphragm. You can't see it very clearly. There's a bit of air around it because there's lung tissue close to the tumor in the diaphragm. So this is not satisfactory because Haifu, the energy that is used to ablate, does not travel very well through air. And so in order to make a good acoustic medium, we have to find something else. And therefore, we first of all have to localize the tumor. So we use transcutaneous ultrasound to mark the spot where we can actually visualize the tumor, where we're going to place the transducer. We degas and degrease the skin, place the patient under general anesthesia, under total intravenous anesthesia with mechanical ventilation, and we use artificial right pleural effusion. I'm sure some of you may be familiar with this procedure, and this is to allow for safe and clear visualization of the structures around the dome of the liver. And that would allow for the lung tissue on the right side to be displaced, and that would allow you to visualize the entire diaphragm and seeing the entire dome of the liver very clearly, as you can see here. And the technique is done by under an aseptic technique. The patient is first anesthetized. We place the patient in the Valsalva maneuver and stop the ventilator, and then we prep the skin with antiseptic and place a 16-gauge 2A epidural needle into the right fourth intercostal space along the mid-axillary line. And where we locate the pleural space by a loss resistance technique. If we get a smooth column of fluid entering the pleural space, then it's going to be very smooth, unrestricted flow of normal saline. And we typically infuse between 600 and 800 milliliters of warm normal saline into the pleural space. And following that, we place the patient back into the right lateral position and get this kind of image here. And as you can see here, the entire dome of the liver is very clearly visualized. The P is a pleural space, the R is a rib, but between the ribs, you can see the entire dome of the liver very clearly. And here's the tumor with the red arrow next to it. Next, we do the sonication. We do intermittent breath holds during sonication. And following artificial right pleural effusion, we can see here, we do not see any lung tissue at all. We can see the tumor very clearly. We can see the entire diaphragm very clearly, and we can sonicate. We can achieve complete ablation of up to 68% of cases if the tumor measures less than 3 centimeters across. And these patients actually make a very good recovery after the procedure. They are typically extubated, sent back to our usual surgical ward, and we do not routinely drain the pleural effusion. We allow it to be absorbed. And there's a very small pneumothorax risk of around 2%. And we typically just do serial chest radiographs, first of all, in the a few hours after the procedure, and then on a daily basis. And as long as the patient is asymptomatic, we let them go home. And the median length of stay in our patients is around 1 day. There's an extremely rare late complication of diaphragmatic injury, but that only happens a few years afterwards. And that's probably due to delayed diaphragmatic rupture, but that was only one case of that. And never have we seen patients who require surgery to treat their complication. And these patients have a procedure which is extremely well tolerated, even in the case of advanced cirrhosis. Secondly, I'd like to talk about what to do if there is a tumor which is close to vascular structures or portal pedicles, because there's always a worry about injury to the portal pedicles or to the veins around and to the bile ducts as well, because there's a dreaded complication of a biloma afterwards. And here we have a patient who had a 2.5 centimeter hepatocellular carcinoma situated in segment 7 of the liver, as you can see here, and we performed Haifu. In fact, what we see here, after 1 month after Haifu ablation, we did this MRI scan with contrast, and here the tumor is completely ablated. There is no further enhancement in the arterial phase, and in DWI, there is actually no signal at all. And here you can see that if you look very closely, you're going to see that the right hepatic vein is completely spared, it's still patent, whereas this tumor was exactly abutting against the right hepatic vein. But fortunately, there was no evidence of an invasion into the main trunk of the right hepatic vein, and there's no evidence of any inferior vena cava tumor thrombus. And so this patient had complete ablation, despite the tumor being right next to the right hepatic vein. And we have been shown, in fact, animal studies and also in vivo studies by Professor Zhou and from Dr. Orsi from Italy have shown that even if the tumor is abutting a major hepatic vein, complete ablation is safe, as long as the tumor is not invading into the hepatic vein. But of course, because of the high flow inside the hepatic vein, we have to be aware of possible incomplete ablation because of the heat sinking effect, which may actually reduce the efficacy of the temperature rise during sonication. So we have to make an allowance to that. But we have to be aware that a portal pedicle is a completely different story, because here we have a tumor which is in a very cirrhotic liver. There is ascites. In fact, the patient underwent transarterial chemoembolization prior to this Haifu. And this tumor is actually close to, but not invaded into the right posterior portal pedicle as shown here. And because there is a few millimeters distance between the main trunk of the portal pedicle and the tumor, and because this tumor is actually in the periphery of the liver, then we can still safely do sonication by Haifu and ablate this. But we have to take extra care, because if we're not careful, if we injure the portal pedicle, the patient may develop liver decompensation, liver abscess, and bilomas. And we definitely think that it is safe if we do it, if the tumor is situated 5 millimeters or more away from a pedicle or a bile duct. Likewise, we have to make sure that we reduce the power of ablation when we run close to the pedicle. So the usual principles of ablating from deep to superficial has to be done, but we have to be careful that we do not go too deep, otherwise we're going to hit the pedicle. Next, here's a 1 centimeter tumor in the segment 4 and 8 of the liver, which is actually, my colleague called me because he said that it's rather close to the heart. And in fact, it's, this is on the diagram on the left is the handheld ultrasound probe, and it's rather close to, but it's still about 3 centimeters from the heart. So we decided that it is still safe. And as you can see here, the patient has a bit of ascites as well. So visualization is extremely good, and good Haifu can be done. But we have to be careful, making sure that we take the usual precautions regarding tilting the probe, making sure that we can see the tumor very clearly. We don't go through any of the ribs. We don't want to risk a skin burn. We don't want to go too deep and hit the heart. We've never had a cardiac injury in our case series of over 500 cases of Haifu, luckily. And as we can see here, Haifu is extremely precise. And next, I'd like to show you a little video about this lady who is quite cirrhotic with portal hypertension secondary to cirrhosis and non-alcoholic steatohepatitis with a large sizable tumor occupying the left lateral section of the liver. Because of the presence of portal hypertension, we decided that she's not a candidate for surgery. And because of the size of the tumor and because of her underlying condition, we decided that Haifu would be best for her. And that's her choice as well to undergo this treatment. But as you can see here, it is rather close to the stomach. It's rather close to the surrounding vascular structures. So we just have to make the usual precautions. But on the Haifu screening, we could not see the tumor very clearly because of the surrounding fatty liver. So we decided that we had to alter the ultrasound properties of the tumor. And so we decided to perform a transarterial chemoembolization first. And by doing highly selective highly selective angiography of the left hepatic artery, we're able to see get a very good blush from the highly vascular HCC in the left lateral section. And we use an iodized oil emulsion plus cisplatin to embolize this. And we're able to get a very good view on subsequent Haifu 2 weeks later. And we got a very good ablation. But because this is situated in the left liver, it's rather close to the stomach. So we had to make sure that the patient's adequately fasted. We gave the patients a fleet enema and enema as well to make sure that the colon is not grossly distended. We insert a nasogastric tube in order to decompress the stomach to reduce the risk of gastric injury. We place the patient in the prone position. And as usual, we place the probe slightly down in order to angulate the probe to upwards so that we do not hit any of the mediastinal structures such as the heart. And we're able to completely ablate this tumor after using up around 741,000 joules over a period of around 2.5 hours. This is the aftermath. The patient had previous cholecystectomy. As you can see the scar here, there's some erythema from the local ablation by Haifu. But after application of ice packs overnight, the patient's skin condition was completely fine the following day, and she went home 1 day later. And the treatment was successful. As you can see here, I placed an X. The X appears to be higher up. In fact, we placed the transducer a little bit lower down than the X, and then we pointed the transducer more cephalad so that it pointed upwards towards the patient's from down towards the patient's diaphragm in order to avoid hitting the mediastinal structures such as the heart. And the patient made a very good recovery without any complication. And here, lastly, I'm going to show you just ablation, a video of a small tumor in the subcapsular posterior inferior segment 3 of the liver. Here, we have to be careful. A nasogastric tube was inserted in order to decompress the stomach. As you can see here, there's probably this hyper-echoic area is actually the stomach and the surrounding omentum, but we can still do a safe ablation of a subcapsular tumor, even if it's close. We do not do ablation if it's invaded into the stomach or invaded into a hollow viscus, but we can still ablate if it's close to it, as long as we control the power. And as you can see here, there's satisfactory grayscale change. And so in summary, ladies and gentlemen, there are certain tips and tricks regarding Haifu for liver tumors in difficult locations. First of all, we have to make sure that we angulate the transducer. We place it a little bit lower down, but angulated cephalad, so that we're looking into the liver from down towards the diaphragm rather than through the chest wall. And secondly, for right liver tumors, artificial pleural effusion is extremely useful in order to visualize tumor lesions in the dome of the liver. If we can't see the tumor lesion very clearly, We can use TACE and then do Haifu a couple of weeks later. And we can assure you that it's safe to ablate when the tumor is abutting a hepatic vein, but we have to make sure that we have at least 5 millimeters distance from portal pedicles or the hollow viscera or from the heart. And so this is a recent review article I wrote in the International Journal of Hypothermia, which I hope that I can share some of my experience with my colleagues, all these esteemed colleagues worldwide. And this is our hospital. This is a view from our wards. And this is our young team. And thank you very much, Chairman.
Thank you very much, Professor Simon, for this very comprehensive and very nice presentation. Can I ask if any one of the audience or participant want to ask Professor Simon any question? So I want to ask you 2 questions, Professor Simon.
Thank you.
You mentioned you choose to treat the tumors below 5 centimeters, not below 3 centimeters. I think this is a very good thinking from your side as a surgeon, because all the guidelines talking about the 3 centimeter as a cutoff line to treat HCC with interventional procedure. So what do you think about your experience about vascular invasion if the tumor more than 3 centimeter, maybe reaching 4.6 like tumor treated by Haifu?
Thank you, Professor. This is a very good question. We've been thinking about this for over 10 years, actually. From our experience, Haifu is a very safe procedure. We have to tell the patient the current data, which is we probably cannot completely, there is a high chance that we cannot completely ablate the tumor if we just do Haifu alone. And so we often combine it with transarterial embolization. If the patient's liver function is satisfactory, that would enable us to treat more than one tumor or larger tumors. And we can also do interval Haifus. We can send the patient back for another procedure, another Haifu session, say a month or 2 after the initial procedure. So we sometimes have to do repeated ablations in order to get adequate coverage of the tumor. But in the meantime, because HCC is a very aggressive tumor, we have to find some other way to control it apart from Haifu. And we find that transarterial embolization is extremely well tolerated, and we offer this in conjunction with Haifu if the patient is suitable.
So very clear. Also, I want to ask you regarding your experience in treating patient with liver cancer. What about the complication you faced? What is the famous complication, and what is the nightmare complication you faced in your experience?
Professor, do you mean treating with Haifu or with?
Yes, treating with Haifu, yeah.
With Haifu, in fact, we've been very fortunate in that we've had very few complications from Haifu. The commonest complication we've had, the commonest serious complication we've had was very early on in our learning curve when we had some skin burns.
Yeah.
The skin burns was secondary to injudicious use of too high a power in between the ribs. We probably could not see the lesions very clearly, and we used too high a power. And the tumor was close to the capsule of the liver, and some of the energy actually reflected off the ribs and actually reflected back onto the skin. That resulted in skin burns. The worst skin burn I saw required a local rotational flap or an advancement flap done by our plastic surgeons in order to treat the skin burn. But luckily, none of these skin burns resulted in sepsis or infection or other complications. So we were extremely fortunate. Other complications which we occasionally see are pneumothoraces. We do not routinely put in chest tubes after Haifu, even after even if we see a small pneumothorax, we only put in a chest tube if there is an expanding pneumothorax or if there's any evidence of respiratory distress. But the last patient I saw who suffered from any form of respiratory distress following Haifu was probably a few years ago. And we can quote that the risk of that is extremely low, less than 1% requiring chest drainage. So these are the two common complications that we see. But apart from these, we've seen nothing else.
And you classified this complication as a minor complication. As a surgeon, this is not a big deal.
It's relative. Some patients required excision of the skin burn and debridement.
Yeah, clear. Thank you very much. Thank you, Professor Simon. Thank you for sharing your experience, and it's a great to hear from you. Now it's a pleasure to introduce Professor Jean Vidal. He is one of the famous interventionists, oncology interventionists, and he had a good experience in treating the patient with Haifu. He treated more than 200 or 250 cases from cancer, from liver and pancreatic tumor, and he will give us an idea about his great experience and about the Spanish experience in treating liver and pancreatic tumor. Professor Vidal, if you please.
Yes, thank you. Let me see. I don't see myself, but I suppose that I'm here. I'm going to share my screen. Okay. Okay, wonderful. Here I am. So I suppose that everything is okay. So let me just do that. Okay, so well, first of all, I want to thank you, the organization, for allowing me to present my experience here. It's always a pleasure to see my friends from Chongqing Haifu and all of you, professors and doctors that share this nice experience of working with non-invasive ablation, focused ultrasound, Haifu, which is one of the best medical technologies that we can have today to fight cancer, to fight tumors. So my experience, as you will see in this presentation, and some ideas that how we have to progress and what's the future expecting to all of us. Let's see. So the purpose of this presentation is to clarify all the questions that probably are the most difficult to see in liver and pancreatic tumors. And because this is becoming now a very interesting field for different companies, different groups of research, to see if with our experience we can help them to not to go through all our learning curve and save them time and resources. Well, this is our experience. The last 12 years, we've been dealing with focused ultrasound, with Haifu, with the JC from Chongqing Haifu and the JC200, and both devices are excellent from our point of view. And we always have deal with the concept of trying to control local disease with non-invasive techniques, and then that this control of local disease can help us to manage the systemic disease. We've done in these last 12 years around 238 malignant tumors, is more than 250 now, and around 90 primary and metastatic liver tumors and 85 non-resectable stage 3 and 4 pancreatic tumors. So in talking about the liver, this is our first study that we included in the first 40 patients. We include patients that were not candidates for surgery or other ablation available, not radiofrequency, not microwave, because that was the standard treatment at this point. And all the patients were allowed to do their systemic chemotherapy before or after our procedure. Mainly, we did 25% primary tumors and 75% metastatic tumors. Only a few percentage of patients did not have chemotherapy, and the majority, 80%, had chemotherapy. And this is the survival course, analyzing the first 40 liver tumors. Total treatment timings were between 60 and 180 minutes. The difficulties were related to patient positioning, access to segments 7 and 8, as our first speaker showed, that were the most difficult situations. But access to deep lesions is feasible with Haifu, access to segment 1, access to tumors close to inferior vena cava. The responses were very successful, 92% in all cases, mostly with no complications, 85%, and a small percentage of complications with burning of the skin and 1 hematoma. And in this case, we had to deal with, resecting and using plastic surgery to cover the defect when we did a burning of the skin. The survival curve shows that is about around 30% at 5 years follow-up of these patients. Going towards the pancreas now, which is probably the most difficult scenario that we have in these cases, and probably what makes Haifu ablation the standard of care, or that is going to become the standard of care for tumors that are not resectable. So pancreas tumor is a priority because of the incidence prevalence of these tumors that is increasing in the world. Median survival is around 18 months. 5-year survival is around 10%. Most of the cases are diagnosed when there is no resection possible, and there is around 450,000 deaths per year worldwide. The anatomy is very difficult, and there are no gender or race-related specific difficulties. We see here how we see the treatment in a JC focus ultrasound Haifu device, and here we see the response. Let me show better with this. We see here the stomach, and going towards the stomach, we can ablate the tumor in the head of the pancreas. So what we did in this case is try to make a comparative experience study. So we had our cohort of patients, and we compared with a retrospective cohort of patients treated at the same institution at the same period of time, only with the standard chemotherapy regimes that were used by our medical oncology colleagues. There was a 7 years observational retrospective comparative cohorts study, and mainly were patients with stage 3 and 4 pancreatic tumors that were treated with the standard chemotherapy at that time. That was chemotherapy with the main combinations. We did focus ultrasound plus chemotherapy, 57 cases, and the control group, 58 patients treated with similar combinations. The chemotherapy combinations were gemcitabine combination, most of them, 58%, and others, the rest. So the responses were seen in 82% of the cases. There were 12 complete responses. We see 21% of complete responses after treatment with the combined treatment of Haifu plus chemotherapy. What a small set of complications, 2 pancreatitis, 2 skin burns, and 1 patient died of a delayed duodenal perforation that was not detected because the patient went out of our facility, went to another hospital, and that there was a delay on the diagnosis in this case. As we can see here, we see here the survival curves with the difference. The survival analysis between the group of chemotherapy alone versus the group of chemotherapy plus Haifu shows a statistically significant benefit for the group of patients treated with focus ultrasound Haifu plus chemotherapy. And the multivariate analysis, the hazard ratio is 0.45. That means that patients treated with chemotherapy plus Haifu have a 45% less probability of dying during this follow-up period, which is very interesting. This comparison that needs to be reinforced with studies, with prospective studies, but as a way of showing that we are in the right way of doing with this case. So that what we can consider that it's I would say the roadmap that we should do, and what we should achieve this is 2 registries. This is a project of a registry, of a pancreatic cancer registry, international registry, that's being done by the Focus Ultrasound Foundation in the US, with all different facilities that treat pancreatic cancer with Haifu. And the objectives are collect data and see if with this collection of data we can prove that focused ultrasound plus chemotherapy in a prospective way is the standard of treatment. Now, what I'm going to explain is what we can think and what we can show that the problems that we can face when dealing with the spaces can be solved in the clinical site with the devices that we have. So we have the problem of the pancreatic cancer, basically is the tumor microenvironment, the fibrotic tissue that surrounds the pancreatic tumor, the difficulties with cancer cell recognition because this tumor is very well protected from the immunity, and the delivery of treatment is difficult to reach the tumor. The immunity is not very well awakened when it's trying to confront the pancreatic tumor. And we may think here that, do we need an ablation, or we just need tumor disruption with Haifu that allows other treatments to penetrate in the tumor and complete the ablation that we're doing with Haifu. So we have to respond with this, with research in the role of hyperthermia, if it's need to be an ablation or can be a low hyperthermia can be of use. How can we deal with this tumor microenvironment? How can we disrupt this tumor microenvironment and the fibrotic tissue to allow the drug delivery inside the tumor? How can we enhance the immune in front of that? And with Haifu, we can obtain some abscopal effect, which is the effect that we can obtain together with the Haifu and the immunity against the tumor. And at the end, the tumor disruption, which should be our main objective. So this is what we face in the systemic, but then there's local problems. And the surgical problems that we face is the possible interference between the small bowel of the colon, the tumor invasion of the duodenum, the placement of a biliary stent that can make difficulties in treatment, the obstruction post-treatment of bowel, biliary, or pancreatic ducts, and the invasion of vessels. And to do that, we need to previously obtain difficulties and avoid bowel interference. So positioning very well, use of water balloon, do not treat the duodenum affected cases because there is a risk of perforation or delayed fistula formation. Always treat after stent placement in the pancreas head tumors. And then we can treat with different angles of sonication to cover the back space of the stent. And do not treat vessels if there is a thrombus inside these vessels. So the recommendations are to use in anesthesia techniques of respiratory gating, avoid shallow breathing volumetry. So use that the tumor is as still as we can have. Do not treat surgical cases. Stage 2 and 3 or borderline patients are the best candidate. Metastatic cases are the best candidates. And there is an area between the head and neck and the body of the pancreas what probably is when 60% of the tumors are presented, and here is when we can obtain the best results. And what not to do: treat tumors close to the duodenum with the risk of fistula, use of water balloon, NG2 placement, and gas minimization procedure as helpers to our treatments. So in the pancreas, we don't have to expect 100% ablations with tumor margin. We have to reinforce the strategies to aim at the tumor microenvironment disruption and work with protocols of combined chemotherapy, targeted therapy, or immunotherapy. And that would be the best area where to treat if we have a tumor of the pancreas. So the ideal candidate would be a tumor at the stage 2 or 3 that had partially responded to the first chemotherapy line, that has a tumor placed in this area between the head and the body of the pancreas, that is not bigger on the pancreatic borders, and there is an absence of any bowel structure between the tumor and the skin. So if we had to write a letter to Santa Claus and ask what would be our future and what we want them to bring us. So we have to consider that the tumor is a substantive entity. The disease is a life inside another life. The disruption of this with less harm to the individual is probably our main objective. We have to enhance our own defensive systems, and we have to deal with cancer stem cells. So we have to break the tumor from the inside. We have to adopt the cancer hallmarks to help us deal with this tumor. We have to face the difficulties for tumor nutrition and cutting ways of delivery of nutrition to this tumor, help with the immune attack, and breaking the structure inside the tumor. So this is all. I am ready for questions. Again, thank you for you listening to me at this presentation. And this is a group of our team that been dealing with our colleagues GYN with the ablation of fibroids. And thank you, and I'm ready for questions.
Thank you, Professor Vidal, for a very nice experience and very clear, sharp edges, how we can use Haifu in treating pancreatic tumor in the future and in the present, of course. Anyone want to ask Professor Vidal about his very nice presentation? Of course, I have a lot of questions, Professor Vidal, because we are sharing the same specialty, and of course, I am interested in your work, a very scientific way of thinking. First of all, of course, we have an experience to treat pancreatic tumor also in our center, but there is a debatable question regarding the stent before treating pancreatic cancer. Of course, my protocol and treatment, I put a metallic stent whenever I can do this in my patients. But Professor Holger and Marinova from Bonn, last episode, they gave us another idea. They treated about 150 cases or more, even more. Most of these patients, they treated this patient without putting a stent or even sometimes with a plastic stent. So I wanted to hear from you about this and what is your experience and what is your opinion?
Well, my opinion is if we have, as I said, the ideal candidate, so if we have a tumor that it's far from the bursum, from the pancreatic duct, and you're sure that you're not going to have problems of possible pancreatitis, and you're dealing with a small tumors, I think that this is a very well idea. So I don't oppose this, and I think that Holger and Milka Marinova have a lot of experience, and they can do it with a small size tumors. But if you deal with tumors in the close to the margin, if you deal with bigger tumors, you need to put the stent, because if not, you're going to have troubles, and you're going to have the criticism of your colleagues that they don't want you to do Haifu, and they tell us that they will tell you that why you didn't do that, because then you can have this problem. So it's more a safe question with bigger tumors than a question of in an institution where the Haifu is very well accepted. For instance, in their institution, the institution of Bonn, everybody agrees with the program. Everybody is very well supportive of the program, and they can do that with all the commitment of their colleagues. When you deal with this and you don't have the full support of your colleagues, you have to take defensive measures, and the metallic stent is a defensive measure.
Yeah,
I'm sorry to say that.
Yes, I prefer like this because also we not working under the umbrella of surgeon. They send the patient and they need to manage everything and send the patient back. So I usually be very cautious regarding this. Maybe this is a different situation in Bonn University. They working in multidisciplinary and the surgeon is protecting them. I think this is an issue. Another question.
There is another thing also that when they send us the patient, most of them, they come up to us with the biliary stent in place.
Yes.
Is what they did at the beginning. In the diagnosis process, when they see some jaundice and they see some risk of jaundice, they just put the stent and then they consult you. And when the patients come to us, most of them have the stent in place.
Okay. They bought metallic or plastic stent, Dr. Vidal?
Metallic, because they think that
from a start. Permanent metallic. Yeah. Okay. What about your experience regarding the response of Haifu for pain? The pain scoring for the patient. It's proving very good after Haifu first session. What's your experience?
I think that probably is the best indication for pancreatic tumors, the pain control, because with Haifu, pain control is obtained, I would say 99% of the cases. And actually is one of the indications in the US, they're going to establish an indication with the FDA for that, because it's very, very, very effective in pain. So in this case, I can say that in my patients, we've been more, I would say, eager to obtain other things because pain was almost always obtained.
Yeah. So thank you very much, Dr. Vidal. It's a pleasure to hear from you. Now I am honored to introduce Professor Meng. Professor Meng from Shanghai Medical University, and he has had a good experience in minimally invasive treatment, and he will share his experience with us regarding the Haifu treatment for pancreatic cancer. Please, Professor Meng.
Thanks very much, Chairman's introduction. And can you hear me?
Yes, of course.
Okay, let's share me the screen.
Please.
So it's okay?
Okay, Professor Meng, everything is working. Go.
Oh,
Go,
thanks. I'm from Fudan University Shanghai Cancer Center, and my job is focused on the liver and the pancreas cancer. So it's my pleasure to have this opportunity to share our experience with the Haifu in the pancreatic cancer. So we know they have widely used ultrasound in the medical area. So mostly it's the diagnosis, and we also can use the ultrasound to treat cancer, malignant or the benign tumor. So the very successful cases, the fibroid. And in our center, we use the Haifu for the pancreas cases more than 10 years. And why we use the Haifu in the pancreas cancer, and only because the progression for the pancreatic cancer is still very, very slowly. And this the situation for the pancreas cancer, the current, and only 10% of the pancreas cancer can resectable, and even after operation, and the 5-year survival was still very poor. And for the local advanced and the metastatic liver cancer, the situation is still very, very serious. And other problems in the past 10 years, the progression for the pancreatic cancer is very slow. So these 2D tables we can see it's the almost similar in the 2012 and 2020. So in the NCCN guideline for the local advanced disease of the pancreatic cancer, the first choice, the clinical trial, but not the systemic chemotherapy. That means the chemotherapy is almost doesn't work in the pancreatic cancer. So in my center, we the equipment we use is guided by the ultrasound. We also have equipment guided by the MRI, but we mostly use the equipment and the ultrasound because it's the more available, and the equipment and the under the MRI is very complicated because it's also it's not in our department. So this is the whole timelines for the Haifu for the pancreatic cancer in our center, and our center is I think it's the biggest center for the pancreatic cancer. It's more than 2,000 new cases a year. So we have a lot of the choice for the Haifus for the pancreatic cancer. So we started beginning of the Haifu in the pancreatic cancer around 2008. So this is the initial attempts in around 2008, and because before the 2008, we are very carefully to use the Haifu for the pancreatic cancer because we know the pancreatic cancer with a very deep organ that very soft, and it's easy to have the risk. So we are very carefully to do some cases, very high selected cases. So around 2008, only 39 cases for the local advanced pancreatic cancer treated by the Haifu, 7 in the head of pancreas and 32 in the body and the tail. But we finished the follow-up and we go back to see the data, and it looked like it's very successful and a very good outcome because the median survival time of these 39 cases is almost 1 year, and the complications are very minor. And the very key point is very amazing results. It's the pain relief in this 39 cases, almost 80%. The pain relief is very successful. So this the almost the first cases give me a very deep impression because the cases diagnosed the advanced pancreatic cancer and treated by the chemotherapy and compared with the radiation. But after the half course of the radiation, the pain and worse and worse. So we do the CT scan, this image, we can see the tumor in the body of the pancreas and involve the vascular. And so we discussed these cases because they failed by the chemo and the radiation. So at that time, we don't have another options. So we try the Haifu for these cases. And why this case gave me very deep impression because after the Haifu, the day after the Haifu, the night, the patient have very good sleep. And the second day, he said, "Thanks, doctor, very much because it gave me a very good feeling, and my pain is almost gone." So we can 1 month later, we do another CT scan. The tumor looks stable, and this situation maintained for 4 months. And the 5 months later, the tumor progression again. So from the 2009 to 2012, so we are to use the Haifu in almost all the new cases for advanced pancreatic cancer. We have done the 224 cases. So in this stage, we treat not only the local advanced, and we also treat the tumor with metastasis because I just said in the first 9 cases, the pain relief rate is almost 80%. So so we use the Haifu for the stage 3 and the stage 4 with the pain. So in this more than 200 cases, the data shows the median survival of the stage 3 is almost 10 months, and the stage 4 is about 7 months. So I think this with the same equipment for the Haifus, the procedure is very similar. So we use the prone positions, and the power we use is about 200 to 40 watts. And the whole process of the Haifu is about 1.5 hours. So they have videos we are that's with the videos we are during the Haifu's process. And sometimes we use the fusion image to help us to locate the tumor. Let me go fast. So we can see inside the tumor after the Haifu, the color is changing. So, but it's the very, very slowly. Okay. So we almost screened the safety data in the 200 cases. So look like safety is not problem because only a few cases have the amyloidosis is increased and some little GI dysfunctions, and only one case have the jaundice. I don't think this jaundice may be caused by the Haifu. So like this case is tumor locate the head of the pancreas and have because the jaundice have a standing inside, and you know, at the beginning, we are worried about if the standing inside the tumor may be caused the reflection of the ultrasound, maybe caused some the desk, the risk of the around the tissues. So in this kind of cases will be down to the power to the 150 and around the 200 watts. So this is the pre-Haifu, the 3 months the after Haifu, and the 6 months after Haifu. So we can see the tumors are stable. And this case is the located the body of the pancreas. So this is the pre-Haifu, so 1 month, 4 months, 8 months, 50 months, and this case is just use the 1 times Haifu. It's maintained almost 2 years, no chemo, no radiation, and this progression after 2 years. So that's you know, just one times Haifu. It's very, very successful. And like this, also in the body of the pancreas, pre-Haifu, 2 months and 8 months, we can see the tumor volume is shrink. And this case is do the PET-CT scan before and after the Haifu. And before the Haifu, we can see the FDG, the value intake in the T of the pancreas. After Haifu, and FDG almost disappeared. So in the 2016, we published another data. So we analyzed the more than 600 cases of the advanced pancreas cancer. And in this analysis, so the survival situation is almost similar with the from 2013 to 2016. But in this data, we have another findings because it's called repeated Haifu and 1 times Haifu. The survival time is different. So because in the first 5 years, almost all the cases we just use the one times Haifu because our medical insurance problems. But in this, after this data, 2016, we found that the cases repeat Haifu is have the advantages of the 1 times Haifu. So because the Haifu we not cure the cancer. So this is the safety analysis of the single Haifus and the multiple Haifus. It's look like it's very similar. It's no problem for the multiple Haifus. It's a safety. And in 2019, we published another papers to combine with the Haifu combination with the gemcitabine-based chemotherapies and versus the gemcitabine-based chemotherapy alone. And so very obviously, the combined Haifus, this group of patients have the survival advantages because we have prolonged the survival time for more than 1.5 months. So I think this in the past about 15 years, so the Haifu is very popular in our center to use for the pancreas cancer. But I think there's some disadvantages of the Haifus, and you know, the pancreas cancer is in a very deep position of abdomen. So sometimes we cannot see very clear in the ultrasound. And the Haifu, we use the low power, and the treatment was during long time, 1.5 hour, 2 hours, and for some very sick cases, they cannot insist on so long time. But this are compared with the other local regional therapies, ablation, Haifus, IFU, and RE. And the Haifu, I think, the advantage is low risk, non-invasive. It can repeatable and low cost. But for the RFV ablation, I have tried a few cases, but finally I gave up because it's very dangerous and it's more risk. And the RE, it's very popular in the recent years because have the normal tissue protection. I have tried about 15 cases. I think it's not easy because it's need very skillful, and the cost is very much. So I think the Haifu in the current situation have a lot of advantages for the pancreas cancer, but most of the field by the pancreas cancer treatment, it's the metastasis. So I think the local regional therapy is not the future for the pancreas cancer, but in the current situation, the progression of the pancreas cancer is very, very slow. I think in the future 10 years, maybe 15 years, Haifu still have a very, very good advantages for pancreas cancer. So that's my experience. Thanks very much.
Thank you very much, Professor Meng, for very nice and long experience in your institute. And of course, your center in Shanghai, one of the most famous center treating pancreatic and liver cancer. Professor Vidal, you have a question for Professor Meng?
Yes, I want to congratulate him for his extended experience, has a lot of patients. And my question is, if he has observed any immunological effect, any abscopal effect treating the pancreatic tumors to other regions, to nodes, to metastases. He has observed that in his group of patients.
So you mean the cases with metastasis, we still use the Haifu to treat it?
Yes, and if you have seen immunological effects when treating the tumor, the primary tumor, you have seen reduction on other tumors, on metastases or on lymph nodes. Have you seen that in some cases?
Oh, so very few. You mean the immune response of after the Haifus? So yes. We hope so. And now we design a clinical trial. We want to find out if after the Haifu combined with the immunotherapy, if it can more helpful to our cases that filled by the first line or second line chemotherapies. we are still waiting for our RB's approval.
Thank you.
Thank you. Professor Meng, I have two questions, please. First one, what is the time you prefer to do Haifu regarding radiotherapy and chemotherapy? Which time you prefer, according to the experience in your center, to introduce the Haifu? What's the time between radiotherapy and Haifu, and which time to introduce the Haifu in combination with chemotherapy?
So in fact, we are always used after the first cycles of chemotherapy, but not with the radiation therapies, because in China, with the guideline of the Haifus, we if the patient receives more than 45 degrees radiation, we cannot use the Haifu. So we are most of cases is just with chemo and the Haifu, and generally we use the Haifu after the first cycle of the chemo.
Okay. Also, you present the case in tail of pancreas, and this area is covered with the colon. How you can displace the colon? Hey, Professor Meng? Professor Meng?
Yeah. Please go on.
I'm asking about the colonic protection during tail ablation. What is your experience in this issue?
So we play the water bags between the patient and with our transducer. So we have to avoid the air inside with the GI tract. So I think most of the cases can see clear of the tumor in the body of the pancreas and the tail of the pancreas, but sometimes it's difficult to locate the tumor inside the head of the pancreas.
Okay. Thank you, Professor Meng.
Thanks, Chairman.
Thank you very much. Let me please introduce my presentation. I will talk about the local regional treatment in treating HCC. Of course, I am very happy to chair this meeting with Eastern and Western School of Intervention because this is a large dilemma in intervention, as an HCC is the third most common cause of cancer-related deaths worldwide, and the systemic treatment remain very limited. The surgical resection is very few number of patients are valid for it. The HCC is a preventable disease. If we can detect, if we can cut this cause, hepatitis and ethanol and NASH, so we can avoid a lot of causes leading to HCC. And in our country, in Egypt, we face a lot of problem regarding the HCC, as in North Africa is considered the third most common place all over the world affected by HCC and cancer-related deaths. And this is in spite of our population is not so large number of population, but we face a lot of problem. So I think in this multidisciplinary meeting, we should know the natural history of HCC and which point we can cut the circulation of developing advanced HCC and when we can treat it. There is a dilemma regarding what is level of evidence level and what is the recommended strong treatment. At the end, we find that the sorafenib or the oral anti-proliferative angioproliferative treatment is widely recommended and used with very high evidence, level of high evidence, and a very high level of recommendation. But on the ground, it's a very poor treating option, and we have a lot of problem regarding this. And so the level of evidence and strong recommendation regarding the choices of HCC, we now it's a dynamic process, and all the world groups now revise the choices for treating HCC. The tumor burden, liver function, performance status are very, very important pillars to take a decision for the patient. We face a lot of problem regarding the HCC, regarding the different staging system, the size limitation, the number limitation, and the vascular invasion. There is many staging system to how to treat the HCC, TNM, Okuda, Japanese, Chinese, Italian, but still Barcelona Clinic staging system is the best prognostic classification to treat the patient. But this classification system, which is the most famous classification system, we have only the option for treating HCC. Less than 30% of the patient will can have a curative treatment, and they put the 3 centimeter cutoff size to use ablative procedure. And after this, they put most of the patient in palliative treatment with TACE or different types of embolization and systemic treatment. But in the last published version of the Barcelona HCC, they gave us more options regarding the tumor, and they maybe reach up to 4 centimeters to treat the patient with HCC. So first issue, in spite of the Barcelona is the most famous classification system, it's provide very low number of or low percentage of patients with curative treatment like surgical resection or liver transplantation and ablation, because embolization and systemic treatment considered as a palliative treatment. So the Eastern people, especially in Hong Kong, starting to make a new staging system, and they released the staging system at 2008. It's they starting to develop Hong Kong classification system, and Hong Kong classification system released at 2015 with a new edge. They consider the vascular invasion is a very important issue, and they increase the size of the tumor up to 5 centimeters. At this point, we can do resection and ablation as a curative treatment. So this is very important if we're talking about the ablative procedure, because the Haifu is ablation. So there is another classification, valid classification system talking about the ablation till 5 centimeters. And of course, the most important thing is the prognostic value of the tumor. In comparison study, the Hong Kong group, they found the Hong Kong classification system with very good results and better prognostic value. So when we go aggressive very early, it's more better for the patient. And of course, we should consider very well the Asian experience in treating HCC, because the Japanese people are the first one to do right lobectomy, and they are the first one to invent the transarterial embolization, and they are the first people using the super selective TACE. So, and even the Okuda system is the first system to merge the clinical of the performance state of the patient and the parameters of laboratory finding of the patient. So the Japanese experience is very important, and in the Japanese Association or a Japanese Society of Hepatology, they make 4 centimeter is another edge for ablation. So you can, after reaching the 4 centimeter, you can make an ablation, even if the tumor is more than 4, but with no vascular invasion, you can do ablation. And you can see this chart showing us what about HCC progression in Japan. In Japan, the progression dropping of the number of the patient of HCC. And regarding the Japanese people, they treat most of the people at the curative stage with 60% of the patient with curative treatment. And this is very important. So the Japanese experience is very important to look at it. And of course, the Hong Kong classification and Chinese association as well. So this study showing us the last 3 decades of experience to treating HCC in Japan. In Japan, they treating about 80% of cases detected by screening. This is very important, how to prevent the progression of HCC. In Japan, they reach about 60% patient with Milan criteria, so the curative treatment maybe reach up to 70%, either surgical or ablation. In Japan, they make a follow-up for survival up to 15 years, and this is great for HCC. Also, they found a very good comparable result between radiofrequency ablation and surgical resection. And this is great. After 10 years, the surgical resection and radiofrequency ablation, the survival reaching up 24%. Also, the Chinese classification is very important. They reach up to 5 centimeter for the tumor valid for ablation. This is very important. If there is no major vascular invasion and the tumor size up to 5 centimeter, you can use an ablation. This is very important. But many hospitals and universities like San Diego, California, they make a merge between Hong Kong and Barcelona and put their guidelines. And I want to give you rapid ideas about the available local regional treatment. Of course, there is ablation like radiofrequency, microwave, cryoablation, and a reversal electroporation. And this is not an ablation, but it's considered as needle guidance. So they put it as needle guidance. Of course, the radiofrequency is the most famous and the most cheap one. And a lot of people has an experience regarding the radiofrequency. And the other issue is embolization. We have different types of embolization: transarterial embolization, transarterial chemoembolization, transarterial dip TACE, what we call dip TACE, and of course radioembolization. In some Asian countries, there is also blunt embolization. The embolization is forming mixture from lipidol, chemo agent, and make a mixing of both and adding a sponge or gelatin gel foam to increase the embolic effect. Usually, we prefer super selective or segmental embolization. But this is very important to make a proper patient selection, proper patient preparation, and the timing for making the chemoembolization. The diptase is more less toxic and more specific. We make a loading of the chemotherapy on the particles and then inject these particles inside the tumor. The radioembolization, we're using the yttrium-90 by the same technique like chemoembolization with some precautions. We inject the tumor, but this is without embolization. This is just introducing the radiation particles to the tumor. And sometimes we used what we called radiation segmentectomy in some cases. Usually, the radioembolization is preferable technique for transplantation bridging. The thermal ablations radiofrequency is the most widely used technique. It's not only related to the power, and some people talking about the microwave as more powerful than the radiofrequency, but it's not only the power. In radiofrequency, we have different types of needle, so we can choose according to the shape of the tumor, which type of the needle we can use. And the ablative procedure now can doing difficult location and using what we called non-touch technique. A difficult location, like Professor Simon did in Haifu, we did a different technique to avoid injury of the bowel and to avoid injury of the vessels. And according to the direction of the power, we use a different needle and maybe perpendicular on the bowel or parallel to the bowel. And also there is a different technique, what we call the non-touch technique. In this technique, non-touch technique, we use two needles and put the tumor between it and doing an ablation for this zone. Also, we have new hopes. The first hope is the radiotherapy. And now the radiotherapy, as professors in Hong Kong or Shanghai or even in Egypt, and I think in most of the European centers, they now using the external beam radiation, but it's still low level of evidence and still weak confidence and weak recommendation. But now we can, in combination with CT or MRI machine, they can do very precise result, especially in portal vein thrombosis. And this is the American Association of Radiation Therapy. They suggest the radiotherapy to be used in some unresectable cases, either alone or in combination with other methods of treatment like TACE or radiofrequency. And I put this slide for a very important issue. We must, as a society, and we must, as a doctors treating and using Haifu, to put the Haifu in as an alternative technique in some cases, not all the cases of HCC and not all the cases of metastasis, to put the suggestion of rule of Haifu to treat the HCC. And this is what I try to do. And of course, all of you doing this. And like this very innovative paper at 2010 by Professor Orsi and Professor Zhang, and they put the Haifu to treat a difficult location HCC, like this tumor. It's insinuated between the branches of hepatic veins and IVC. You can precisely see the tumor and treat it. Like this tumor at the hilum of the liver, insinuated between the IVC and the portal vein. No any other methods of ablation can do this technique. Like this case, for one of my cases, this patient complaining from very small hilar tumor at the liver hilum. We can't do ablation by any methods, and his lab is not good. He is not suitable for TACE, and we treating him for by Haifu and in single session, and we follow up them up to 2 years. And you can see this is post ablation. 1 month is completely ablated tumor. Even at 6 months and 12 months, we hardly appreciate the tumor. We can't even see where is the site of the ablative zone. Also, we can put the Haifu in these cases after TACE, like Professor Simon showed us, after TACE with borderline size tumor, we can use Haifu as alternative treatment after TACE. You can see this is case of large tumor treated with systemic therapy with residual tumor. We do TACE, and this is the residual tumor. It's marginal tumor and with large crescent area at this point. And this is a PET scan showing us this is residual tumor at the hepatic dome. We make an Haifu for maybe 2 hours, 2-hour session, maybe 2,000 sonication, and this is the results. We almost ablate all of the residual surrounding the tumor, and we follow up the patient after 9 months. There is no residual. Also, this is very important indication for Haifu. Some patients are out of Milan criteria. Maybe the alpha-fetoprotein more than 1,000. And they need to make a transplantation, and they have ascites. And we have this small lesion. We make a pre-transplantation Haifu for many patients in our center, even with ascites. And you can see this is an ablation after Haifu, and this patient go for transplantation. Another indication not related to HCC, like metastatic liver lesions and cholangiocarcinoma. The cholangiocarcinoma is very, very good indication for Haifu because it's hypovascular, and we can treat the patient very well by cholangiocarcinoma, especially if peripheral type. But I'll show you one of the more difficult cases. It's a central type. This is 25 years old man, pathologically proven cholangiocarcinoma. We can see this is the central type. We put a stent, metallic stent, and treating the patient, and you can see this is very good response. And even the track of biopsy is ablated. And this is MRI and CT after. Of course, we can put the Haifu also in a small HCC lesion in normal location as a start to compare it with the radiofrequency, like this study by Professor Tantu, and of course we missed him today, and he have a very good result as comparing the Haifu with radiofrequency. Regarding the metastatic lesion, it's another issue. We must introduce the Haifu, like Professor Vidal talking about the immunomodulation and immune response, because the Haifu is not only mechanical destruction of the lesion, but it's improve the drug delivery and improve the immunotherapy of the patient, and change and alternating the nature. And you can see, of course, all of you have a very good result about this small metastatic lesions, very good, very easy, very accessible, and you can see a good response easily after the tumor. And this is very easy case. You can see what we called even like a hemorrhagic coagulopathy, and this is the very good sign of very good ablation. This is indicating the Haifu is strong, it's not weak. And this is very good result of very simple case. Also, I show you this case with metastatic lesion insinuated between the bowel and the liver surface. And after Haifu, very simple case, you can see this is like a wedge-shaped ablation. This is also a very good indication that the Haifu is strong, and sometimes you can't see the infiltration of the tumor, but the Haifu is spread throughout the infiltrated area. And this is good also. Sometimes we do a Haifu, and if the lesion is responding to the ablation, that means it's not a normal hepatic tissue. This is also another indication for this very simple case, but it's just below, behind the portal vein, and we can't reach it. The Haifu gave us a very good result. So in metastatic lesion, it's not only an ablative procedure, but also it's a modality of treatment enhancing the immunomodulation, improving the quality of life. And I think the Haifu should be giving us better results if the distance is lower, the size is smaller, the vascularity is less, so we can get a better result. And we should put the Haifu in this area to treat the patient. Thank you very much. Thank you very much. Anyone have a question? Yes, Dr. Simon, please.
Hi, Professor Hamed. Thank you very much. Yes, it's incredible that we're able to perform Haifu in so many different indications. But I cannot agree with you more regarding the how we consider Haifu as an ablation, because what we see Haifu is, it is actually the ablation modality which can be used even in very advanced cirrhosis. And that is when everything else fails. And I think that's where we should place it, because it is not for early disease. It is actually the last resort in some of our patients. And because the morbidity and mortality relating to Haifu is so low, and that it is repeatable, we can easily do that successfully, even in very borderline patients. And I think that we should seriously think more about combining Haifu with TACE. And that's why I seriously agree that we should expand the indications for Haifu for larger tumors, because it is repeatable. We can combine it with TACE, and it works very well as well. And yeah, I'm very curious about your experience regarding the treatment of hyalocholangiocarcinoma.
Yes.
Did you actually experience, was it actually at the portal confluence, or was it very peripherally located?
I actually I treat maybe 7 cases with cholangiocarcinoma. We're preparing the paper now to publish. Most of the patient, the response is complete, especially in the peripheral location. but I just put this case because this is astonishing case, because this is not usual to have this great response. I wanted to put it as an alarm for all of us. We can use Haifu and cholangiocarcinoma, and this is great for the patient. Also, there is an entity, Professor Simon, what we called cholangiohepatoma, and this is now is existing on the ground in many cases. Also, we did a test. We found the lesion is not hypervascular. At this issue, we can make a test with Haifu. I agree with you totally. We must expand the indication of Haifu, but we face a problem. We must do this as a recommendation from multiple centers, not like a personal experience or individual experience. This is we need make it like the radiotherapists make. They put the radiotherapy as a suggestion in some cases. Okay, I hope I justify the answer for you. Any more question? Any more question? Okay, now I am very happy to introduce my dear friend, Professor Zhu from second affiliated hospital from Chongqing University. I'm very happy to see you again. I attend the cases with you and I saw you many times. He is a clever man, he is an experienced in treating many cancer liver patient. I saw him treating this patient very easily. And I think second affiliated hospital in Chongqing, one of the best center treating the cancer patient as a routine, because if you go to this hospital every day, you can find the patient treated with cancer pancreas, cancer liver metastasis as a routine. So this is what we call common practice treatment. So I think he can add for this meeting. Please, dear Zhu, give us your experience.
Thank you, Mr. Chair, Professor Mohammed. So right now I go ahead to my PPT here. Well, can you see this? Can you see my screen?
Yes, it's clear. Okay.
Well, thank you, Mr. Chair. Thank you, everyone, to join this meeting. Actually, in China, it's late. So my topic is Haifu clinical application for liver tumor and case report. And this is our hospital. It was founded almost 130 years ago. And this is our excellent Haifu team. You can say of them. And I'm one of the member. Well, also our center is the national training base for Haifu treatment, which was from September 2005. During last 20 years, I am lucky to have been working with over 500 doctors in 120 clinics from 29 nations and regions. So in my experience, I have cases with the tumor in the head, on the chest wall, in breast, in the liver, in the pancreas, and in the kidney. Also, the benign diseases in uterus, the tumor in leg, in adrenal glands, in the bone, the tumor inside the abdominal cavity and even on the bottom of the feet. So sometimes I see the indications for Haifu ablation is from head to feet. Here, there is a video to show a tumor on the chest wall. The case from IEO, Institution of European Oncology from Milano, Italy. We see the tumor right on the chest wall here. It was divided into slices, and we put the focus right on the tumor. One solution, one grayscale change. And dot by dot, we ablated the tumor completely. After the final one, I put my finger into the water tank to touch the skin because it's so close to the skin. I touch it to make sure if there are any burn happened. So finally, we found that nothing happened, no injury to skin. And the tumor was ablated completely, even with the nutrition blood vessels survival from the Haifu treatment. We use the value of grayscale change to indicate the local ablation. Generally speaking, if the value changed 10 units, we say it is ablated. That means the necrosis. So far, we have two clinic guidelines in China. The first one was published in 2005. The second one was published last year. It indicates us the indications for Haifu ablation. So there's a question, what is the role of Haifu ablation or Haifu treatment playing in treatment for malignancies? I have two stories. The first one is for breast cancer. In 19th century, the surgical treatment is a standard one for breast cancer. The 5-year survival was 30% more or less. And 50 years ago, it was thought that the local therapy have no influence on survival. The surgical treatment plus the systemic drugs together, it prolong the survival time. Right now, the long-term survival rate for early stage breast cancer is over 90%. The second story is for osteosarcoma. During the year, the pre-chemotherapy year, the long-term survival is only 20% with the surgical treatment only. But with the chemotherapy, such as the neoadjuvant chemo and neoadjuvant chemo, that means the modern chemotherapy year, it achieves a long-term survival rate over 60%. The same story happened in our center. We found that for those bone malignancies with the 2B stage cancer and chemotherapy, we achieve almost 8% long-term survival. So I believe that there are two foundation stones of tumor therapy. One is the systemic treatment with the chemo, TKI targeted agent, immune treatment, and the local treatment is surgery, Haifu ablation, radiation therapy, thermal ablation, TAE or TSAE. So I have two cases to show you that the first one, we say that HCC plus the right adrenal gland metastasis is a stage 4 when the patient was 45 years old. We chose the TAE plus Haifu treatment for that. Finally, we got a complete CR response after TAE plus Haifu. After that, we have a very good long-time disease-free survival of 17 months. But after that, we found that a new tumor appears on the right portal vein tumor thrombus. We use Haifu ablation again to ablate it and to keep the blood supply from this right branch of portal vein to protect the liver function. But unfortunately, we found that the PVTT happened to the left portal vein and more and more. We ablated the PVTT, but finally we lost this patient at 36 months. The second one is with HPV infection and no antivirus drug. So this patient was diagnosed as primary liver cancer, HCC plus PVTT in another hospital. The solafølimab was performed as a first-line TKI agent. But 3 months later, the solafølimab did not work well. After that, we choose a TAE plus Haifu to ablate the tumor. After that, we say the main body of the tumor was ablated, but the satellites, lesions around it was not. Then we change the medicine to Radiotherapy as a second-line TKI agent. With that, 1 month later, the primary lesion shrunk, but we found a new lesion happened in segment 7. We decided to use Radiotherapy more time. On 5 months, we found that the tumor, the newly lesion in segment 7 is larger. So we performed another TAE plus Haifu ablation for that. With the economic reason, there is no post-Haifu CT. After that, we found that the tumor grew bigger and bigger and invaded into the right hepatic vein, even with the IVC. So at this moment, it's on 2020, the price of the medicine was cut off. So it's possible to use PD-1 plus Radiotherapy together to control those disease. Luckily, we found that the PD-1 plus Radiotherapy works well. Only 2 months later, we found that the tumor was much smaller than previous one. So the PD-1 plus Radiotherapy continues. Go on. At 26 months, we see no tumor thrombus in IVC, but a tiny one in right hepatic vein. And right now, this gentleman is still alive. The follow-up is with the follow-up. So I think that probably there was no such best therapy for the patient, but with an appropriate treatment for patient, sometimes we need to try to find out a good local ablation plus an effective systemic agent together to control the patient and to prolong the survival time. So there are already published articles to show the effective affection of the Haifu treatment for small HCC. This one from Japan, we say the tumor was ablated completely and with a larger enlarged ablation. And this is from our colleague, Queen Mary Hospital. They compared with the results from Haifu ablation and RFA. It was found that the same OS and the same DFS was indicated. And this one this article was compared the recurrence after HCC resection, the diameter less than 5 centimeter. Those patients was divided into two groups. One is with Haifu, ultrasound guided Haifu and ultrasound guided RFA. The other one is with open approach RFA. Finally, we found out that for all cases, the DFS and OS are similar. For cases under ultrasound guided therapy method, the DFS and OS are similar too. And this one is from our center. We found that the patient with HIF only compared with HIF plus TACE, the OS 2-year was 89%. They are similar too. So we believe that for the small HCC, HIF ablation will play a great role like other local thermal ablations such as RFA. They should be with the same results and with the same complications. Also, we have experience with HIF ablation for large HCC. Sure, the long-term survival will be worse than those from small HCC. Our colleagues published articles from here, and this one is from our hospital. And there is a meta-analysis to involve the 9 controlled trials with over 700 cases. It says that TACE plus HIF ablation improved the tumor response and the 1 to 3 year survival. So another meta-analysis involved 42 articles and over 5,000 subjects. It says that also says that TACE plus HIF appears to be the most preferable therapy. We believe that the TACE plus HIF ablation together will prolong the survival time and with better survival rate. So, and there are some special conditions. Back to these published articles, this group patient is with the size over 7 centimeter with 42 lesions, all of them near major hepatic veins. We see that the tumor in segment 1, 2, 3, 4, and right or left lobes, and near IVC right middle left hepatic veins, and the portal vein right or left branch of the portal vein. We found that there is already with survival benefit, and we see that the tumor near the portal vein here, and the portal vein here, and the hepatic vein here, and IVC here. We found that there was no major blood vessel injury observed in all of this group. So we believe that just like the case we have seen from IO Italy, the blood vessels will be safe from HIF ablation. And if the tumor was blocked by the ribs, as we all know, the therapeutic ultrasound will be reflected by the bone tissue of the rib or the calcification. So it needs breath control to move the tumor from behind the rib side into the interspace between two ribs. With this, the therapeutic ultrasound will reach the tumor. If there was a large size tumor, it happens the same. For those part appears in the interspace between two ribs, it could be ablated as routine. And with the breath control, we move the blocked one part into the interspace between two ribs. Another method is to intrapleural cavity injection. This picture shows the normal saline injected inside the pleural cavity. This is the liver, and this is the dome. Rib is here. It is a black shadow in the ultrasound image, and this is the end of the long tissue, and this triangle part, is the normal saline. With this, it will create a good acoustic pathway to help us to ablate the tumor completely. Say this is a case, a male with 42 years old with ABCC. We say the tumor was blocked by the ribs here, and here, and blocked by the lung tissue. With those two methods, we could ablate the tumor completely. And then this case is from our colleague, Professor Tong Yang team. They are from the Ningbo Huamei Hospital of Zhejiang, China. This tumor is between the liver and the stomach. We found that the tumor was ablated and shrunk after 1 month, and there was no visible injury happened to the liver or the stomach. And this is another case from Professor Tong Yang. We say a tumor in segment 4 near the heart and near the left branch of portal vein. We see here the left branch of portal vein here, and this is the dome, and it's a very tiny one. After that, there is a strong hierarchical change happened, and with the Solview injected under the CUS contrasted enhanced ultrasound, we say it was ablated completely. This one is from Professor Tong Yang too. We found that this part was ablated previously, but a newly one appears here, and a very tiny tumor. See, this is the IVC. It's so close to the IVC, and during treatment, the hypoxic change happened again. We see the IVC clearly. So just like Professor Simon shows, the tumor near the dome could be ablated completely. This case is from our team, and this one is from University of Hong Kong. The same. Well, this case is from our team. Say this older gentleman is 81 years old with the pancreatic cancer liver metastasis. We say that 1, 2, 3, 4, 5, 6 lesions. Six lesions ablated in one half session on November. It's 2.5 hours to complete those 6 tumors. We say the tumor near the diaphragm, and near the portal vein, and even near the duodenum. This is a success ablation. Well, this case shows the natural course of a patient with portal vein tumor thrombus. On September 14, 2016, the tumor invaded the one of the branch of right portal vein. Only 1 month later, it grew into the other branch of the right branch portal vein. It was said that the natural growth is 12 millimeter per month. So this is the another case. We can say that the PVTT right here on the right portal vein with the sodication, I have got the hypertrophic change right here. So we could ablate the primary liver cancer and the portal PVT together in one session. There is a published article shows that for those patients with PVTT invaded two branches of portal vein, there will be survival benefits. There are cases, say this one is tumor in segment 4 with the PVTT on left branch. After ablation, the size of the primary HCC shrunk and the PVTT inside the left branch disappeared. This case is with a large one in segment 5 and segment 6, which was not shown in this slides. But we can see that the tumor invaded the right branch of the portal vein. 1 month later, we say the PVTT was ablated and the flow of the right branch of portal vein appears again. Well, this is a case. We say a huge tumor here, and it invaded into the right branch of the portal vein. With the TACE plus Haifu treatment, we say the tumor was ablated completely, and after that, another TACE performed. We say the size of the tumor gets smaller and smaller, and no more PVTT appears in the right branch of portal vein. Well, this case shows a tumor near the gallbladder. We found that the tumor was ablated completely, but no injury happened to the gallbladder. This case shows a tumor near the colon. We say that it was ablated completely, but no injury to the colon. This tumor is near the HeLa region. We found that after ablation, and this one shows the biliary flow after stent placement with the pressure of the tumor. We say the stent was pressed. There is only a thin line. After that, we say with the shrunk of the tumor, the stent opened widely. Well, this case, the next cases, I'd like to share some video to you. And we see this one was nothing on 2011. And on 2013, there is a small HCC happened on segment 8. With the first Haifu ablation, it is a successful CR response. But unfortunately, this year we found a new groove tumor on here again, and we ablated it completely.
Professor Zhu, please.
Yeah.
2 minutes to finish, please.
Oh, okay. I will speed up. We'll go ahead. Another one. This is a cholangiocarcinoma. We see here, and ablate completely. This before and this is after. And this case is near the dome. It's a colon cancer with liver metastasis. And then this is another one with a single large tumor we see it's right here. And after that, it looks like something left. So we performed a second one. After that, a complete ablation and with size shrink. This one is HCC after recurrence. After resection, we ablated with that, the size shrunk. Well, I have no time to show share the video. Anyway, I can make some conclusions. First, I believe the Haifu treatment, Haifu ablation is one alternative local thermal ablation method. It could play a tumor ablation, drug target delivery, and immune upregulation function for the patient. We found that it is safe for large blood vessels, and there is no limitation for size of a tumor. And it could be a conformal thermal ablation. And finally, I believe that it should be with systemic treatment agent, TKI, PD-1, PD-L1, CTLA-4, chemotherapy, together to benefit the patient more. So I believe in the future, Haifu treatment or Haifu ablation will be a good tool, a good method for us clinical doctors, and it will be benefit for more and more patients. Haifu high life. 谢谢大家 Thanks. Dank. Grazie.
Thank you very much. It's very great. Thank you, Zhu, for a very nice presentation and very wide application for Haifu. And of course, your center is one of the very important center to treating cancer in China and outside China. Okay, any question for Dr. Zhu? Okay, of course, I have a question. I think one of the most problematic cases is a portal vein thrombosis.
Yes.
So if we can put the Haifu as a line of treatment for main portal vein thrombosis or lobar vein thrombosis, we can put the Haifu in very good choices for the treatment of the patient. My question, you have a long experience and your center treated a lot of cases. What about portal vein thrombosis as a Haifu indication? And what is your experience in this?
And so far, we found that we can stage the PVTT as different stages. If the portal vein tumor thrombus grew into the ISMV, we think it's a very late stage and we can do less for the patient. But if the PVTT is only on the right or left branch of portal vein, it will be very good benefit for survival. So far, we found that we have the experience of around 15 months for those patients with PVTT. And if the PVTT limited in the branches of right or left branch portal vein, it will be over 20 months survival time. And I think if we can find out the tumor right on the left branch or the right branch, it will be the best choice for the patient, and that will be the best survival benefits. Okay, did you publish these results and technique for portal vein thrombosis? Not yet. Actually, the article is under preparation. I believe it will be published tomorrow or next year.
Next year, okay. I want the first published paper for me, because I think
Why not?
this will increase indication for Haifu in many places all over the world. I think this is very good indication.
Yeah.
Thank you, Zo, and thank you for your of course I have a lot of questions, but I can ask you later, because we have short time to introduce Professor Yang, the director of minimally invasive tumor, chief physician, and he is a medical oncologist. Of course, he can share us his experience. He has a lot of papers, a lot of sharing and treating Haifu patient. Of course, we will be happy to hear from her his experience about treatment of progressive stage of pancreatic cancer, and I think this is a very good issue to learn from him. Professor Yang, please.
Oh, thank you, Chairman. Can you hear me?
Yes. Hello.
Okay, let me share my screen.
It's great for us.
It's okay?
It's okay.
Okay, thank you. Now it's so late in Beijing, so good evening and good morning, dear professions from the 5th Medical Center of the PRA General Hospital in Beijing. The topic of my report is application of Haifu for the treatment of progressive stage of pancreatic cancer, a single center experience. We know that pancreatic cancer is called the king of cancer. In 2020, the global cancer registry data showed that the incidence of pancreatic cancer ranked 12 in the global cancer incidence rate. Although not a high incidence rate, but it ranked 7th in cancer mortality. Its development in rapid, its prognosis is very poor, and the 5-year survival rate is very low. At present, the study suggests that surgical resection is a displacement method for the treatment of pancreatic cancer, but about 16% of them have metastasis at diagnosis, and 25% in already local advanced, and only 15% can undergo surgical resection. In recent years, although the disease has made some progresses in surgery, chemotherapy, and other fields, but the long-term survival of pancreatic cancer patients is still not ideal. Therefore, the main direction of research is to strengthen transformation and clinical research and explore precision treatment under MDT mode. At present, local ablation technology is used more and more widely in the treatment of tumors. The main technologies used in the clinical treatment of pancreatic cancer included radiofrequency ablation, carrier ablation, IRE, and Haifu. The role of local ablation treatment is considered to induce reduction tumor load, prolonged disease control time, elevating cancer pain, and improving patients' quality of life. We know the Haifu can lead to a variety of biological changes after entering the body. Among them, the effect ablation refers to the structure changes that can produce coagulative necrosis. In addition, some Haifu devices and mouses cannot achieve ablation effects, but can only produce function and changes, which is not what we discussed today. So, therefore, not all Haifu are focused on ablation in the clinical application of tumor. Focus of ultrasound treatment technology which can achieve ablation effect is more important. Our center indications for the use of Haifu in treatment of pancreatic cancer included tumor size, physical condition, and treatment desire, and etc. The treatment control indications mainly included the safety indexes of treatment channel or organ function, treatment position, and so on. This is the method and the specific treatment parameters for the treatment of pancreatic cancer in our center. The method of point scanning is usually adopted with an average power of about 400. Try to arrange treatment under general anesthesia. Our previous study showed that Haifu can achieve good local ablation effect in the treatment of pancreatic cancer. In the clinical study of 18 patients, according to the ISMIVS evaluation criteria, OR can reach 18.3% and the DCR can reach 19.6%. Let's share a few cases. This is a 14 years old female patient with pancreatic neck ductal adenocarcinoma with lung metastasis and significant abdominal and lumbar pain. After Haifu treatment, the pain score decreased from 7 to 2. Pancreatic tumor necrosis was significant. The patient survived for 18 months after combined chemotherapy. This is a 59 years old female patient. She was given 2 cycles of article chemotherapy after surgery, followed by focused ultrasound ablation under general anesthesia. After operation, she was given oral chemotherapy and survived for 24 months. This is a 65 years old male patient with pancreatic poorly differentiated adenocarcinoma. He had received IRE treatment before, and our Haifu treatment time was about 14 minutes. The postoperative pain score of Haifu decreased from 8 to 2. This is a 45 years old male patient with pancreatic tile cyst adenocarcinoma. Tumor necrosis was significant after Haifu without pancreatic fistula and pancreacia and pancreatitis. This is a 59 years old male patient with pancreatic neck adenocarcinoma. After Haifu treatment, the local focused necrosis was significant and gradually absorbed and shrunk. The patient was pancreatic and tile. The treatment channel was established through the spleen to achieve completed ablation. There were no serious complications after operation. The second feature of Haifu is the treatment of pancreatic cancer is the effective control of cancer pain. Our initial and later study have shown that the pain relief rate is more than 94%, whether it's treatment under general anesthesia or not. It can also be seen for literature report that Haifu can achieve more than 18% cancer pain relief rate in pancreatic cancer, no matter whether the ablation effect is achieved or not. Another characteristic of Haifu in the treatment of pancreatic cancer is the effective discharge of the celiac nerve. We have conducted a study to compare the efficacy and the safety of Haifu in the treatment of pancreatic lesion combined with celiac nerve damage. The combined treatment group was treated with Haifu for pancreatic lesion and celiac nerve, where the control group with only treatment with Haifu for pancreatic lesion. The study shows that the OR of both groups can reach more than 82%, and the DCR can reach more than 91%. The pain relief rate and the median pain relief duration in the combined treatment group were 95% and 7 months, where those in the control group were 19% and 3 months, respectively. Comparative studies also show that the incidence of abdominal tumor progression in the combined treatment group decreases, suggested that it might to be related to blocking the pathway of pancreatic cancer along the celiac nerve. The statistics of the complications show that the complication of the two groups mainly included fever, pancreatic injury, and impaired gastric emptying. More than 19% were mild. Relatively, the incidence of the impaired gastric emptying in the control treatment group increased slightly. All complications recovered gradually. Compared with the control group, the recovery time of gastric emptying disorder in the combined treatment group was prolonged. Our study showed that Haifu can prolong the survival time of adenopancreatic cancer. Can prolong the survival time of advanced pancreatic cancer, both the early study and the paper over the age of 60. The median survival time of stage 3 and 4 patients after Haifu combined comprehensive treatment can reach 16 months and nearly 10 months, respectively. Among them, the median survival time of stage 3 patients receiving Haifu, comparing chemotherapy and radiotherapy can reach about 24 months. In addition, Haifu treatment of pancreatic cancer lesion combined with celiac nerve destruction also seems to help prolong the survival time of patients. The analysis of clinical influencing factors showed that OS could be significantly prolonged in patients with Haifu combined with systematic treatment and ablation efficacy above PR. Briefly discussing several topics. First, not all Haifu can achieve ablation effect. Our studies suggested that ablation effect is a significant factor affecting OS. Therefore, it can be seen in some literature that the survival benefit of Haifu treatment is not obvious, but the local treatment effects is not mentioned, which may be related to the poor effect of local ablation. In addition, we once found a case of anti-tumor immunodistant defect caused by Haifu treatment. This is a 56 years old man patient. We only performed local treatment of pancreatic cancer by Haifu and did not perform other anti-tumor treatment. The local necrosis of pancreatic tumor can be seen from the follow-up data. The result of the examination 2 months after operation showed that untreated pulmonary metastases were significantly reduced, suggesting that Haifu treatment may lead to the occurrence of anti-tumor immunodistant effect. This is a very interesting case. In addition, the complications of Haifu treatment need to be paid close attention. We know that non-invasive treatment is not without trauma. Haifu treatment of pancreatic cancer is in some treatment center has had serious complications such as intestinal preparation. Therefore, we need to familiarize ourselves with the treatment machines, standardize the technical operation, and do well in the management of perioperative period. Finally, let's me make a brief summary. Haifu has the advantage of non-invasive technology in the treatment of pancreatic cancer, which can effectively alleviate cancer pain, improve the quality of life, and extend the survival time by achieving ablation efficacy and combined systemic therapy, but still need to pay attention to research safety and combine treatment stages. That's my report. Thank you very much. I'm sorry, your voice.
Thank you. Hello, it's now okay. Thank you, Professor Yang. A very illustrative and very nice presentation. And your talk opened our mind regarding some issues all of us talking about, but the proof is not in our hand. So you gave us a proof about 2 main issues. The first one is the celiac plexus ablation. We noticed some cases not improving so well after Haifu ablation, and some cases improving very well. You intending to ablate the anatomical site of the celiac plexus, and this is good. And the other issue is the immunomodulation occurred at the distance metastasis. I think these 2 topics are very nice to talking about, to publish about, and to make brainstorming about it. So any one of our audience need to ask Professor Yang about his nice presentation. Okay, I have a very small question regarding using the spleen to go through with a Haifu. Is it dangerous, Professor Yang? I think this is dangerous to avoid the splenic rupture or splenic injury. What's your experience about this?
in our operation, we treatment for about 15 seconds and take away the from the skin. So the prolonger the duration after treatment, the energy input the skin. So it can be save the skin and other organ.
Yes, but you introduce a case, you show us a case, you go through the spleen to treat the pancreatic tail tumor. You face any problem in this case?
No, we can know this question.
Okay.
Okay.
Okay, thank you very much. Thank you for all professors participating in this very nice webinar. Anyone need to give a comment? Professor Vidal, Professor Simon, Professor Yang, my dear friend Shu. Anyone need to add a question or a notes or anything?
No, thank you.
No, thank you. So can I suggest a group picture? Everyone, please give us a chance to open the camera, and we can go to the group picture to have all of our audience. Yeah. Please, please open the camera, please. Hello. Surprise, yeah. Rebecca, it's a surprise for you. Yeah. Hello, Raul. How are you? Hi. Hi, Tony. How are you? Hello, Samir. Okay. Okay, thank you very much for your time, and it's a great event, and all of us add a knowledge to each other, and I hope to meet again and again in similar meeting. Nice to meet you, and I hope to see you all face to face very soon.
Yes, very
Thank you.
soon. Thank
Yeah,
you.
okay. Okay. Thank you very much. See you.
Thank you.